Instead of the extended release long-acting opioid talk, which the feedback from our past listeners were, well, why are we learning about this? It was because we had grant funding that required that. And also, it's, the more you know about opiates, the more you understand them, generally speaking. But we took it upon ourselves. Dr. Sullivan, who was going to be speaking on that, suggested that the CDC opioid guidelines are going to be a much more interesting topic. And I put something together on it, and we're going to do a walkthrough of the CDC opioid guidelines. So you will be prepared to be the local champion of this. So, Randy, is this available as a PDF for people? Yes.
It was sent out.
The other one was sent out.
We just got, this is a new one. Have you sent this one out yet?
No. Okay.
Okay.
All right.
It will be available.
All right. This will be available as a PDF, which we will get out for you. I apologize. Literally hot off the press.
Yes, it is.
It can't be hotter off the press than my putting it together, finishing it about 45 minutes ago. So I just handed it to Randy. The CDC, or the U.S. Centers for Disease Control and Prevention, and I think the prevention is partly driving the considerations here, and opiate overdoses are subsumed in their poisoning category. So this would be an unintentional poisoning category as far as the Centers for Disease Control are concerned. Did produce these guidelines, and I'm not able to advance. Okay, is the battery off or something?
Yes.
Yep, there we go. All right. I'm beginning to learn, but I still can't turn the switch on myself. Okay, good. So no disclosures. We have some dwindling grant support at this point. And I will discuss some medications that are off-label for pain, but the focus will not be necessarily on the drugs, but on the guidelines themselves. So really recommend everyone, you just Google it, and it's interesting, 111 comes up every time I transfer this document to a PC off my Mac. But there are 12 recommendations. They're really worth knowing. I think are regulars. Just because I only can see Dr. Logan and Dr. Bergman, I bet you could present these yourself, and I would expect say, well, of course, but they are new to a lot of folks. And the three topic areas, they've broken it down to when to initiate or continue opioids, how to select, choose a dose, for how long, how do you follow up, and how do you discontinue? More on when to discontinue rather than how to discontinue, but nonetheless they address that topic. And then assessing risk and addressing harms is how it's broken down. If you just Bing or Google CDC opioid, this is the first hit right now, right to their site, and you can get the copy of this for yourself. So I'm going to walk through the 12 specific recommendations. At the top, I've shortened it because it's quite a long little section there, and you could read all the language, but I've edited it for our conversation here today. The first portion in red and underlined, et cetera, that's the actual language from the guideline. Below it, with the bullets, with the italicized black, is my own discussion points that I wanted to bring up with this audience for our own ability to understand what to do about this. So the first is non-drug or non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. And I don't think this is anything different than those of you who've been long-term or even newcomers to our program. And this is driven by evidence for benefit. Some of it is not compelling, class 1A evidence, but much of it is at least, if not more, than that to support opioid management. And certainly lower risk. Cognitive behavioral therapy, physical and occupational therapy, mindfulness. We talk about Tai Chi, we talk about yoga, we talk about just general restructuring of one's life, reframing one's life. These are not drugs, and these work better than drugs. And again, no reported overdoses of mindfulness yet to be reported. Yes, Mark.
So I just wanted to alert people, Dan Churkin and Judy Turner have a paper in this week's JAMA showing that both CBT and mindfulness-based stress reduction are effective treatments for chronic back pain. And I think the most notable thing is that both of the treatments, and most surprisingly, the mindfulness treatment, continues to become more effective after the intervention ends. And its most impressive time point was 52 weeks out. So that I think that's pretty impressive for a back pain treatment. And that's just in this week's JAMA, latest one. And a nice editorial, too.
And I'm presenting this to a University of Washington administrator meeting on Monday morning to explain why we need more CBT providers because they're interested in this as well. So this is what's driving it. If we're going to talk about pharmacological therapies, again, I've listed some of the key non-opioids that we've been discussing: tricyclics, SNRIs, gabapentinoids. I did aspirin, products, the NSAIDs or acetaminophen as other alternatives. They're more for acute and active nociceptive pain. The biggest challenge here that we're expecting is access to the CBT. In our clinic currently, it could be 6 months till you get in to see one of our providers, which is not timed properly and does not lead to the kind of outcomes we're looking for. And then health benefits coverage, particularly in the Medicaid population, which gets no behavioral health support unless you're seeing a psychiatrist. And with the exception of present company here, I don't think very many folks are paying much attention in the psychiatry field to the cognitive behavioral therapy side in the general psychiatry community. So the challenge with guidelines when they're telling you, provider, you must do these things, but you can't do these things, this is a concern. And they are considered by many as effective de facto regulations. Because I'm supposed to be doing this, I'm not doing this, I'm at risk of disciplinary action if I don't. So we're pushing this hard to begin to get the top list, most importantly CBT, PT, OT, mindfulness, and in a longer discussion we extend that out further into the conversation in the state of Washington, the healthcare authority, and I'm happy to say we're meeting with insurance company folks and big health plan folks to be able to convert guidelines for prescribers to guidelines for health systems and insurance entities, because that's the next big step. And I hope that we make progress, and I'll keep you appraised as we do move forward on this. Okay. This conversation, Dr. Erin Krebs, a colleague of ours now in Minnesota, she presented this at as a keynote talk to the American Academy of Pain Medicine. The guidelines weren't yet released, but in anticipation of them. And after she talked about this, she looked at the audience. She said, she's got a great grin. She says, "This is mom and apple pie." And she got an applause from that audience, which 5 years ago she would have been booed and hissed. So the societies are moving as well in that direction. Okay, number 2, still under the initiate and continuation. Before starting opioids for chronic pain, clinicians should establish treatment goals and realistic goals for pain and function. Again, mom and apple pie. And even more important at the bottom, and if they don't prove evident by evaluating pain and function, you discontinue because it isn't just about pain intensity. And these realistic goals are directed by we, the primary care providers, in the conversation with the patients. I want to be able to play contact rugby, and they've had 5 spine fusions. I mean, obviously that's not a realistic goal, but that is an extreme example. Working with the patient to establish realistic goals. And how do we do this? I alert people to Joe Merrill's motivational interviewing. The famous line. So how's that going for you? To get people on board with the troubles that they're having and setting reasonable, graduating forward progressive goals. This is not detailed and spelled out, but I would, again, say our experience working with you so long, I bet you can fill in all the blanks if anyone has any objection. And who could object to setting realistic goals with your patients? Again, initiation and continuing, this is the last of that first set. Before starting and periodically during, you talk about risks and benefits. Again, this is so basic, I think it's called informed consent. You talk about risk, you talk about benefits. And this is something that will trip up primary care providers if they don't note this in their chart and their patient has a bad outcome. I think this is an exposure issue. The Washington State law, 2876, otherwise known as, also calls for this. And having looked at some medical records and reviewed them, you want to insert this or provide, and we have a informed risk benefit form. It's available. It's posted on our website. Use it. You can blame it on us for the languaging on it, but you could have them sign that, keep a copy, and keep a copy for your own records if you're really concerned about medical legal issues. And the second is the patient and clinician responsibilities. That's the pain contracts, bad word, but that's what people know that, or otherwise known as the opioid treatment agreement. What you expect from them and what they can expect from you in terms of respectful, evidence-based, harm-reduced type care. And that, again, I believe is posted on our site as well, the UW document that we put together here.
So,
yes, absolutely, Mark.
So one point I like to make at this concerning opioid contracts or treatment agreements is that short-term and long-term opioid therapy are not the same therapy. It's the same pill, it's the same drug, but it has very different risks and benefits. And so I think, what I would have added here is that when somebody's crossing the 90-day threshold, you need a new conversation about you could be on this for the rest of your life. This has these long-term effects, and it's not the same as here's 7 pills for your wisdom teeth. So,
good. You know what? Thank you. This is the first edit draft. I'll take feedback from anyone else that doesn't make any sense. I think that's a great point. I don't think the CDC does not suggest that.
No, I don't think that. I didn't see it.
Yeah, I don't recall seeing it. I read through it quite a number of times. But periodically during chronic opiate therapy. But it would be very reasonable, and that's a really good, innovative idea, Mark, thank you, to have 2 agreements. One is periodic, perhaps, but that the chronic opioids have their own special considerations. Okay, a few slides now on opiate selection, dosage, duration, follow-up, and discontinuation. And they've lumped it together in here, and I think it's helpful to frame where we're moving. You can see we're already a third of the way through, and it doesn't get any heavier than this. So this is nothing that you don't well understand. So when starting opiate therapy for chronic pain, clinicians should prescribe immediate release instead of extended release long-acting opioids. And that is, again, was going to be the sole topic. You have a slide set on it. You probably do well to take the COPE REMS, Mark's work, available free, no more free CME, but you can still take that course for free and get certified for it and learn about the extended release long-acting opioids. But my comments here are why start a drug with prolonged activity when you haven't even seen its effects for short activity, for goodness sake. You haven't seen the benefits and you haven't seen the adverse effects. And you're going to be starting with a drug that is at a higher dose, that are at a fixed dose. In other words, it doesn't give you much mobility. And nearly all of the extended release opioids you can't cut, crush, chew, break, because that causes dose dumping. So these are not the first-line therapy, and I doubt many in this audience would think of that, but plenty occur when we see consults coming in from a variety of other sites around the state. First drug is OxyContin, 10 milligrams BID because it's easier than taking it 4 times a day. No, it is not recommended. And in fact, the Earl of REMS do not recommend that, and this simply calls out start with immediate release. I'm expecting Mark to jump in is when would you ever use an extended release long-acting drug? Palliative care, cancer pain care, And in an occasional circumstance where the dose duration isn't enough to hold your patient through their functional activity, but giving it at night to help sleep is not a good idea, because that's what causes people to stop breathing at night, is the opiate at night. And the quality of sleep on an opioid is poor. Slow wave sleep is disturbed, and REM sleep is also interrupted. And those are the magic sauce for getting restorative sleep and for your descending inhibitory, normal, healthy pain pathways to become reactivated again. Okay. Number 5, 5 out of 12. When opiates are started, prescribe, again, mom and apple pie, the lowest effective dose. That seems quite reasonable. And what's different here than even the Washington guideline is probably there's 2 contentious items in these guidelines based on the public comment. A lot of opioid advocates thought a lot of this was contentious, but this was one of them that caught a lot of eyes, that the CDC is calling for doses above 50 morphine equivalent to put your patient at significant risk, and doses above 90. So we use the 120 number in this state. There's a history of why we basically made that up and looked at the reality of the number of people we'd be responsible for making changes on. But as the data trickles in, basically there's risk at any dose. 50, below 50 tends to have a lower risk that shouldn't make us that concerned. But above 50, the point of deflection of adverse effects, including overdose and death, do begin to rise. So they have reset the dose limits to a lower level. If you look at the 2015, July 2015 Washington State guidelines, we had a big discussion about this, partly because we expected this to be coming. We didn't know it at the time. But decided to just have a whole paragraph describing this rather than change the dose limit. I think someone in the room said, well, we'll let the CDC, who may be lowering the dose, do the dirty work for us and not distract from all the other points that we were making. So they've done, I think, a good deed by reminding it. I teach our medical students, mostly primary care. We deliver 60% of our students off to primary care practices. I say for primary care docs, who's in the room? And over half the way, raise the hand. It's a small group discussion. 50 is the dose that you should pull the brakes on and say, what am I doing? Where am I going? Is this working? And what harms might I be causing? And certainly at 90 is a caution. Okay, next in the sequence about selection, dose, duration. And Mark, I welcome you to join in because this is a work in progress communicating this. When chronic opioids are used for when opioids are used for acute pain, this is the only acute pain conversation that they have. So everything else is chronic. Prescribe the lowest effective dose of an immediate release opioid. And here's the contentious point. No greater than needed, which no one would argue with, but then they call out 3 days or less will often be sufficient for most acute pain, and more than 7 days will be rarely needed. In the original draft, I think 3 days or less will be sufficient, period, and they didn't add the other caveats. So obviously for acute pain, limit the quantity of pills to match the expected need. We don't want to do it just for convenience, so they don't call you or they're not bothered. That leaves the 90 of the 100 you've given them in the medicine cabinet where they're going to be pilfered by teenagers, housekeepers, other family members, who knows, or maybe a temptation for that individual to take that when they're having a bad day. Or a pain in the neck interaction with their family. Oh, well, that pain is enough for me to take. So it keeps the opioid supply pipeline down to a trickle out of a water fountain instead of a fire hose that's left on, which is the current state in this country. The problem issue is, and when we talked about this in our Washington State Committee discussion, we were talking about a week, 2 weeks or 4 weeks. 4 weeks is way too many. 2 weeks we chose simply because of access, because a lot of patients may not be able to get back to the primary care provider or the prescriber's office within 2 weeks, especially after a big surgery. They may not have transportation. they may be hundreds of miles away if you're in a rural community. And to get them back to an office to get a refill at 7 days may be difficult. So if you're going to do more than 7 days, say why. That'll cover you in terms of how to navigate the guideline. We elected to give 2 weeks based on limited access, transportation issues. That you thought about that, you acknowledge that, and you've made a specific decision that you're going to go beyond the guideline recommendation. But 3 days, the most common primary care practice considerations, typically 3 days of an opiate would be enough. And that's going back to old-fashioned prescribing patterns. And this, again, is a topic that became highly contentious and delayed the guideline release by about 2 months. Okay, I think the rest we can go through pretty quickly because they're self-evident. Recommendation number 7 is evaluate benefits and harms periodically. So within the first 4 weeks of starting the therapy, and then periodically at least every 3 months. The Washington state law astonishingly says 1 year for evaluation. The Washington state says 3 months. I would say in my years of practice, 3 months is the outer limit of feeling comfortable prescribing opioids to patients even before the current era of huge angst about what's happening with the medications. And again, if benefits do not outweigh harms, you should continue other therapies. So don't do opioid monotherapy alone. So don't forget, it's not just opiates, but it's all these other things. And then if they don't improve the outcome, taper them and consider stopping them entirely. So don't escalate if it's not helping, and taper and or discontinue if harms are greater than benefits. Again, it seems like what we would do with any medical treatment. Diuretic management for hypertension, diabetes management for our diabetics, cardiovascular disease management. This is, again, just basic principles of primary care practice.
Could you give an example, David? Not to prolong this too long, but I know that we had to go into a lot of detail about this because a lot of doctors kind of feel cornered, or they don't really know how to weigh harms and benefits in a way that allows them to come to consensus with the patient.
Oh, Mark, always causing trouble.
It's easier said than done is what I'm saying.
Well, it is easier said than done.
And they don't offer guidance in the CDC guideline about how to do it.
Yeah, well, we don't know specifically how to taper. They propose a couple of tapering
or how to weigh
strategies.
benefits and harms even.
Yeah. All right. So, let me tell you. So, what do you think on this? Yeah, this is a Joe Merrill motivational interview. All right. So, tell me what you think about
I'll tell you what
this.
we did in CoPrems. What I suggested was, one, to kind of lay out what the goals were ahead of time, and to specifically not allow those goals to be framed in terms of pain intensity.
Okay.
I want to be able to do X.
So they slightly call that
at the beginning.
Yes.
And you write that down. It's what the patient said and you agreed on. And then later you apply what you agreed on before to say, you know what? You're not doing these things. Or this has not happened. And so we have not met your goals. And this is the time to make a decision. So we are going to taper or something like that. Because I think if you leave the definition of benefits and harms and goals till when you want to do this, you can be in trouble.
Okay, good. Nice suggestion.
And I think that a lot of docs are trying to do the right thing. They're trying to honor the patient's report of pain. They want to believe the person's in pain. They believe they deserve benefit. And the patient will throw back all that stuff in your face, even if they're like sleeping all day.
Okay, good. All right, so assessing risk and addressing harms of opiate use. Tom, let's circle back when we get to it. Assessing risk and addressing harms. This is the concluding the last few guidelines. Evaluate risk factors for harms, and if the patient's at risk of overdosing, I personally don't prescribe, but that's too much risk compared to the potential benefit. But if you are moving forward with opioids and the circumstances merit that, they've demonstrated improvement in function and pain, factors such as a personal history of overdose, Again, astonishingly, 98% of people who overdose on opioids, when they return back and get their next prescription of opioids, they are higher than the dose that they were on before they overdose. So instead of stopping them, they actually get resumed and often at a higher dose. So if they're overdose, you would certainly consider this high risk and consider naloxone. History of substance use disorder, higher opioid doses above the 50 MED number, or if they're using concurrent benzodiazepines. So bottom line, when high risk for ODs, think of co-prescribing naloxone, and that's either a nasal or injectable kit. Pharmacists in the state of Washington, I believe, can just be asked, and it's dispensed over the counter by pharmacists. But you, as a prescriber, can write that down, self-administered. And there's a couple of products out there now. They're pretty expensive, but that would be reasonable for, obviously, the person's overdose. They can't self-administer. But a family, a partner, a caregiver, someone in their local environment will see that they're looking very bad and not breathing and can rescue their lives. So this is new. Again, our Washington State guidelines included in the naloxone conversation, but the CDC elevated this to a higher status. Number 9, check the PDMP. Pretty straightforward. I don't think there's much dispute about that. And when starting opiate therapy for chronic pain, they do not require it to be looked at before you initiate your first dose of opiates. 5 pills for acute injury, a couple days, a week or so, that's one thing. But when you're in the chronic range, you are recommended now to check the PDMP. It's cumbersome. It should get easier, and this, again, is a health systems problem to be able to make these more available at our desktop in our busy day when we're running through quite a long list of patients. Okay, recommendation number 10, when prescribing opiates for chronic pain, do urine drug testing before starting the therapy and consider UDTs at least annually. I think we know a lot about it, and coincidentally, Dr. Rapp, our UDT expert, has just entered the room behind, coming out of clinic. Thank you, Susie, for joining us. And the guideline number 10 recommendation of CDC is called out urine drug testing, and they are just important risk screening. Some recommendations that we've heard from you folks is have a standard clinic policy so you don't single out individuals. So X date, we automatically do that. They're not being identified as a problem. It's just what you do in this clinic. And the national recommendations now recommend that. And they don't say how often. We recommend based on risk, but it's also based on what you feel is appropriate in your clinical practice. Never is not good enough. Sometimes, yes, and as often as needed is the key point. Recommendation number 11 in the guidelines, nearing the end, a clinician should avoid prescribing opioids and benzos concurrently. I thought they were too soft whenever possible. I think it would be rarely necessary. But we know benzos are dangerous in combination with opiates, and they are not evidence-based treatment for anxiety. Antidepressant category medication is best. Tricyclics for sleep or gabapentinoids if needed. And if you're using benzos for PTSD, we see a lot of that. Maybe consider prazosin. That's an off-label indication for the PTSD symptoms that often reduces the patient's anxiety enough that you consider getting off benzos. Finally, last recommendation from the 12, offer or arrange buprenorphine or methadone treatment when you've made a diagnosis of opiate use disorder. And again, in combination with behavioral therapies for addiction management. I think what's special about this is it's reminding us that a good chunk of our patients on chronic opiates are actually being inadvertently by us being treated for opiate use disorder. And if they meet DSM-5 criteria for opiate use disorder, and you're prescribing opiates for them, and you are not licensed to do so, i.e. a methadone license for addiction, or buprenorphine and naloxone, i.e. Suboxone certification, you are in violation of federal law. So this is, again, if it looks a lot like opiate use disorder, you got to take it seriously and make a referral for that treatment.